Dr. Suman, we will start.
Thank you, sir. Thank you for your, I'm humbled with your introduction. Okay, let's see. I'm Dr. Suman. Today we are going to talk about ARDS. The next 30 minutes, I think we'll divide this ARDS topic into probably 2 or 3 topics, where half we'll cover about the basics of ARDS, what is the understanding of our ARDS, and then next subsequent topics we'll talk about the how do we manage ARDS. So before we understand what is how do we manage ARDS, we must understand what is an ARDS and which patients we call this patient is an ARDS patient or mild, moderate, severe, whatsoever. And we must also understand what is the basic pathophysiology that is involved in ARDS, so that if you understand the basic pathophysiology involved in ARDS, then your lines of management, be it whatever the subsequent management that we are going to talk about ARDS, be it your ventilation or non-ventilation strategies, multiple aspects will be completely based on the pathophysiology that is involved. With the understanding of pathophysiology only, or the concepts of ARDS, then only you will be able to manage the patient of an ARDS. So with this brief introduction, now in next 30 minutes, we are going to talk about what is the definition for pediatric ARDS and what is the basic pathophysiology involved in ARDS. Third most important concept called baby lung concept. So what is the baby lung concept that we are going to talk? So before we go into the definition of ARDS, so what are the causes for ARDS? You have a direct causes where because of infection, be it like pneumonia, aspiration, inhalational injuries, or you have indirect causes like be it sepsis, septic shock, or dengue viral sepsis, or transfusion related acute lung injury. All these are indirect causes. See, if you see, there are certain important diseases are not involved in this causes of ARDS because they are not ARDS, which we will talk, which are not ARDS. So with this, we'll go into the definition of ARDS. Probably one definition I would tell all the people to might not be able to remember, at least keep this in thought that there is a definition for ARDS. When you're talking about any child, this child is an ARDS or whatever it is. When you're talking about ARDS, make sure that your child is fitting into this ARDS definition. If you're not fitting into ARDS definition, then you cannot apply the principles of management of ARDS to this particular patient. So if you see the ARDS definition evolved over the years, initially it was given by Murray and AAC. For many years, it was Berlin classification that has been followed. In 2015, the first time pediatric ARDS definition has come into the picture, that is PALIC 1 guidelines, that is in 2015. And then again, PALIC 2 has given the new definition in 2023. That is the reason. Am I audible? I think my internet connection.
Yeah, you are audible.
PALIC 2 guidelines have come in 2023. That is the reason I'm not asking you everyone to remember the definitions, mug up this definition, but at least you must understand there is a definition for pediatric ARDS. You have to put your clinical condition into this definition, whether this definition is fitting into, whether our patient is fitting into ARDS or not. As I said, the principles of management of ARDS are completely different from the other aspects of the disease. So we'll go through a few case scenarios to understand which is an ARDS, which is not an ARDS. I hope my residents are available, are there. Sirisha, you're there? Farah? Is anyone here? Are residents? Okay. So let's see this case scenario. We have a 12-year child who came to our ER in acute onset of respiratory distress. There was a history for cola-colored urine and decreased urine output. At admission, the child was in cardiorespiratory failure. So acute onset of respiratory distress, came in cardiorespiratory failure. So we have intubated this child and started on ventilation. And initial ABG showed PF ratio, PaO2 by FiO2, that is around 60. Oxygenation index we know what is oxygenation index. Map into FiO2 by map into PiO2 by FiO2. Map by into FiO2 by PiO2. So that is 22. And we have done 2D echo that is showing severe LV dysfunction. This is the X-ray of the patient. So I want everyone to think about it. So we have an acute onset of respiratory problem, and you have a PF ratio in your ABG showing 60 and oxygenation index of 22. And you have an X-ray over here which shows clear-cut bilateral opacities in your lung fields. A 2D echo showing severe LV dysfunction. Is it an ARDS? So that is a question we have to answer. So is it an ARDS or not? I would say this is not an ARDS. Chat box, we have message. Yes. Oh, not able to unmute. Okay. Right. Can anyone tell this is an ARDS or not? So someone said, yeah, no, absolutely right. So the reason for saying no, this is not an ARDS because you have underlying cardiac dysfunction. The X-ray that you are seeing is bilateral pulmonary edema secondary to cardiac dysfunction. So that is why this is not an ARDS. Let's go with the other case scenario. So we have a 12-year child, case of severe TBI, intubated and mechanically ventilated because of neurological purpose. As the child neurological condition improved, the child was given spontaneous breathing trial. And on day 4, we have observed that after spontaneous breathing trials, there is an acute worsening in the oxygenation status. Again, ABG showed PF ratio of 94, oxygenation index of 60. So this is an X-ray of this particular child. Again, my question, is it an ARDS? You have complete homogeneity on your right side. Complete one half of the lung is completely homogeneous. So shall we call this as an ARDS? So again, what are the responses we have got? Again, said no. No. Yes, universally everyone saying no. Reason, it is not because there was an unilateral involvement. The reason is it is a lung collapse. It is an acute lung collapse that lead to your respiratory worsening. So hence this is not an ARDS. This is an acute onset of lung collapse that led to your worsening your oxygenation parameters. That is not an ARDS. Let's put the other case scenario. 11 months girl child, cough and cold from 3 days, rapid breathing. In view of severe respiratory distress, we have intubated the child. And you have a bilateral, you have few homogeneous and you have some non-homogeneous opacities on bilateral lung fields, intubated child. So, and your 2D echo is normal. Viral panel showed H1N1 pneumonia and PF ratio is less than 100. Oxygenation index is more than 24. My question is, again, is it an ARDS? So I am looking for the responses over here. The third scenario, is it ARDS? So I have answers saying that yes. Someone said no. Only one person said no. Dr. Sumati said no. Rest all agreeing with saying that it is no as an answer for yes as an answer for ARDS. Okay. So now that only we need to understand. As I said, that is the reason we must understand what is the reason, what is the ARDS definition. First two case scenarios, the ARDS, it is not ARDS. Third case scenario, it is ARDS. You have a viral pneumonia as the picture, and this viral pneumonia, you have your PF ratios less than 100, oxygenation index less than more than, I think it is given as 16 in our case scenario, and your cardiac status is normal. And the insult is within 4-5 days only. So I would label this child as an ARDS. With this understanding, so you have different scenarios of different ways of involvement in the respiratory system, and you labeled few diseases, few as ARDS and few as non-ARDS. So hence we need to understand what is an ARDS, which category of patients are fitting into ARDS. So before we understand the ARDS definition, we must know what is PF ratio, PaO2 by FiO2, oxygen index, map into FiO2 by PaO2. If it is oxygenation saturation index, if you replace PaO2 with SpO2, then it becomes oxygenation saturation index. Now this is PALIC 2 definition. I want you to go through this just a second. Sorry. Good afternoon, sir. Okay, చిన్న ఆన్లైన్ సెషన్ లో 15 minutes. Yeah, make call this. Okay. Now we have PALIC 2 definition. So this one slide, very, very important. Two subsequent slides, I guess. So these are very, very important in understanding what is the definition of ARDS. See, age. You can spend some 2 minutes over here. Age which does not include perinatal lung disease, number one. The insult should be within 7 days. Okay. The insult should be within 7 days. Third, origin of edema. It is not explained by cardiac failure or fluid overload. So these two conditions should not be explaining the edema in the lungs. And when you have an image, it chest or X-ray, it can be, this should be new opacities, which are either unilateral or bilateral. Previously, people used to call only bilateral involvement as an ARDS. No, unilateral or bilateral, consistent with pulmonary parenchyma disease, which are not primarily due to atelectasis. So, second case scenario, I showed you TBI. There was a gross lung collapse. That was so your pulmonary parenchyma is not attained by atelectasis or pleural effusion. You have a large empyema or large pleural effusion in dengue. Do we call it as respiratory worsening and you have a large pleural effusion? Do we call it as an ARDS? No. All your parameters, you would not call it as an ARDS. So these are the four criteria, and after that you have an oxygenation. If you are doing invasive mechanical ventilation, your oxygenation index is more than 4, or oxygenation saturation index, as I said, you replace PaO2 with SpO2, it becomes oxygen saturation index. If it is more than or equal to 5, your AS. If you are doing a NIP, invasive ventilation, NIPPV or something like that, where PAP is less than or equal to 300, or if SPF ratio, if you don't have PO2 and you're falling SPO2, then SPF ratio less than or equal to 50. That fits into ARDS. Internet was weak, so I got disconnected. Probably, I don't know from where I've missed it. I need to restart again. Where from where I got disconnected?
Sir, from the PALIC 2 table.
Definition, table itself.
Yeah,
Summary
yes,
of the
yes.
table itself.
Yes. From table itself, it was not, I think from half of the table, your voice was not clear. So we can continue from the oxygenation
Right. First
criteria.
four
and all.
points. First
Yeah.
4 points, I think,
Yes.
was it
Yes.
audible? Okay.
Yes.
So after the first 4 points, I would say that, for after the 4 points, then we have to decide rest of the definition of ARDS or fitting into ARDS is based on your oxygenation index and PF ratio. See, even if you have a what do you call SpO2, that is good enough to label as ARDS. If you have SpO2, then you can calculate oxygenation saturation index. So if you are using invasive mechanical ventilation, OA more than or equal to 4 or oxygenation saturation index more than or equal to 5 will make fit into the ARDS definition. If you are using NIV, that is NIV PB or something like that, if your PF ratio are less than or equal to 300 or SPF ratio less than or equal to 250, that fits into ARDS. And the second part, if you are stratifying the ARDS severity, it is always must and mandatory. You have to wait for 4 hours, optimize your ventilation, then only you have to stratify, not immediately after intubating or getting an X-ray done and stratifying an ARDS. So previously people used to call it mild, moderate, severe differently. Now the new definition says if you are using invasive mechanical ventilation, OI less than 16 and more than 4 will fit into mild or moderate category. If it is more than 16, it is severe category. If you are using NIV, again, it is based on PF ratio. PF ratio more than 100, but it is less than 250. It is moderate. I request everyone to mute yourself. So if you are using NIV, then also we can stratify the type of ARDS. Mild, moderate, PF ratio less than 250 and more than 100. If it is severe, PF ratios or PF ratio less than or equal to 100 or SPF ratio less than or equal to 150. Again, I'm not asking everyone to mug up or remember this definition, but remember that there is a definition for an ARDS that is given by PALIC 2, and we have to see whether our disease of whom we are ventilating or doing NIV or HFNC are fitting into ARDS or not. That is what I wanted to make. So we have to rule out this acute deterioration is not because of your cardiac disease or it's not because of your chronic lung disease. This is per se definition. And there is a criteria for NIV as well. So again, the first 4 points would be similar like invasive mechanical ventilation. The new change is if you are using not only NIV, if you are using HFNC, high flow nasal cannula, then only at that point of time also you can label someone as an ARDS. If you are using HFNC, then with more than 1.5 liter per kg per minute of flow and your PF ratio is less than or equal to 300 or SPF ratio less than or equal to 250, then also you can say it is a possible ARDS. We cannot say ARDS, but we can say possible ARDS. So I want everyone to go through PALIC 2 guidelines about the definition of ARDS. Take a printout, keep it in your ICU or wherever you're working, and then try to fit into all your children's having pneumonia, whether they are simple pneumonias or they are an ARDS. And if they are ARDS, try to stratify them into moderate or severe ARDS. That concludes my talk about ARDS definition. So now understanding the definition, the concepts that we should understand irrespective of the number is an acute lung collapse will not be an ARDS. A pulmonary edema secondary to secondary fluid overload or cardiac failure is not an ARDS. A massive pleural effusion or ascites leading to respiratory worsening is also not an ARDS. That is what the bottom line regarding the ARDS definition. Now let's go into the pathophysiology of ARDS. It's actually little boring only to talk about pathophysiology of ARDS. Dr. Nitin has requested me to talk about pathophysiology also. That's the reason I have few slides on pathophysiology. It's boring, but yeah, but if you understand the pathophysiology, then probably all your ventilation strategies or non-ventilatory strategies that is followed in ARDS will be more clear to us. Then you will have a base for your understanding and the management. So the basic principles or pathophysiological mechanisms involved in ARDS are first, number one, alveolar capillary barrier dysfunction. There is an alveolar capillary membrane that leads to disruption, and you have a surfactant dysfunction which leads to alteration in your pulmonary mechanics. Then there will be a mechanism which usually clear the alveolar fluids that will be a defective, and thereby all this leading to your change in the gas exchange, which increases your shunt or ventilation perfusion. There will be host immune response. We are releasing a lot number of cytokines, And because of all this, there will be cardiovascular dysfunction. So this in brief, let's go individually into each aspect. So this is a normal capillary and alveoli. Usually you have a tight junctions between this alveoli and capillary. We will go very briefly only. I'll not go into the details. So there will be tight junctions. There will be minimal fluid between alveoli and capillary normally. That is decided by your oncotic pressure and hydrostatic pressure within the capillary. These are, if you see the alveoli, you have type 1 alveolar cells, you have type 2 alveolar cells, which will have a surfactant production. This yellow line is surfactant. Whatever you see, this is an surfactant. So you have few macrophages alveoli. So this is a sodium potassium pump where extravasation of fluid happens through this pump. This is normal capillary and alveoli. So if you see, this is completely a distorted capillary alveolar membrane and structures. So you see there is a neutrophils going into the alveoli. The surfactant is disrupted into small yellow molecules, and your disruption of this sodium potassium pump, your fibroblasts, which were minimal previously, have increased. Your fibrin layers have increased. This is what happens in ARDS that we are going to talk in detail. So when there is an injury to either to the epithelium or pulmonary capillary, this provides a neutrophil activation, and because of this, you will have intercellular connections being disrupted. Because of this disrupted intercellular connections between capillary and alveoli leads to unregulated fluid and protein and cytokines into the alveoli. Normally from capillary, only the fluid will go, never ever a protein goes into the alveoli. Because of this disruption, because of direct injury or indirect injury that we have learned previously, there will be extravasation of protein, neutrophils, cytokines all into the alveoli. So there will be extravasation of this fluid and protein into the alveoli, leading to alveolar edema. That is the first point. The second point is surfactant dysfunction. Because of this alveolar macrophages or neutrophils, there will be chemokines that will be released. This will disrupt your surfactant, and the alveolar fluid itself will disrupt the what do you call surfactant, and leads to a decrease. We know in alveoli the surface tension is maintained, and because of this your alveoli is intact, and this surface tension is created by surfactant. And when your surfactant is lost, then what happens? The alveoli tend to collapse. So when the alveoli tend to collapse, then what happens? The most two important concept that happens in pulmonary mechanics because of decreased surfactant and alveolar edema is, one is decrease in lung compliance, and there is an increase overall airway resistance. So what is this hysteresis? Hysteresis is PV loop, right? So where change in volume to the change in pressure, with minimal change in pressure only, the volume change will be maximum with the hysteresis loop. This is what the hysteresis loop is. Now with the change in the pressure, you change in the volume, right? So in ARDS, because of this alveolar edema and decreased surfactant, more of this cytoskeletal injury, your lung compliance will be reduced. What is lung compliance? Change in volume to the change in pressure. Normally with even minimal change in pressure, the lung volume change will be maximum. When your lung compliance is good, it will be maximal change in the volume because of change in pressure. If your lung compliance is reduced, even with maximal changes in the pressure, your volume change will be minimal. And because of this small alveolar collapses and airway collapse, your overall airway resistance also gonna increase. This is a pictorial representation of your PV loop, and as I said, your how your when your what do you call, alveoli get collapse, how this pulmonary mechanics are going to change. So again, how the resistance is going to be increased because of this Poisson equation, which I'm not going through. Third mechanism is there will be decreased alveolar fluid clearance. As I said, there is a sodium potassium ATPase pump. Because of this being defective, the fluid that is inside the alveoli will be not be cleared, and that is the reason your fluid edema or alveolar edema will be continuing. So ultimately, because of permeability edema, you have a reduced compliance, and this because of reduced compliance, your alveoli will be end expiratory lung volume within the alveoli will be decreased. It will be decreased to a level it is less than the functional residual capacity, which is nearly to the closing capacity. Your end expiratory lung volume is reduced because of your tendency of alveoli to collapse will be more. So because of this, you will have a regional atelectasis and you have a multiple capillaries, but you don't have alveoli for shunt or for gas exchange. That leads to intrapulmonary shunting and thereby leading to alveolar hypoxia. So finally, what happens? There will be intrapulmonary shunt and ventilation perfusion mismatch leading to alveolar hypoxia. So these are the four important mechanisms. One is alveolar capillary membrane dysfunction because of injury leading to edema formation, and this leads to surfactant dysfunction leading to alteration of pulmonary mechanics. As I said, decreased compliance, increased resistance, and there will be defective mechanism of alveolar fluid clearance also. That is the reason you have persistent alveolar fluid inside, and this leads to alteration in gas exchange because of you have increased shunts and you have increased ventilation perfusion mismatch. This is general response. Now, what is host immune response? So, what is host immune response? I would not go into the details of it. Because of because of lung injury, there will be immune responses. These immune responses are very complex. That there will be complex interaction between your cytokines, complement system, phospholipid metabolism, and coagulation cascade. All this leads to your thrombi formation or fibrosis. Let's go into the details of this. You have a permeability edema leading to different alveolar mechanics, then leads to alveolar hypoxemia, and because of complex nature of coagulation cascade also involved, you will have thrombotic forming in the pulmonary microvasculature, and next fibrosis. Because of this, your pulmonary vascular resistance is going to increase, and when your pulmonary vascular resistance is going to increase, then there will be increased right ventricular afterload. Because of this, your cardiac output is going to be compromised. This is the end of the ultimately this is the end. So again, when you have no, in ARDS, what is the concept? This is a very important slide for us to understand. That is the reason where you have this 4 ml per kg, 6 ml per kg, 8 ml per kg. Thus, that points have been lost for the same reason. The lung volumes on pulmonary vascular resistance. Your pulmonary vascular, this is the total pulmonary vascular resistance. Total pulmonary vascular resistance will be very high if your lung volumes are very high. If your lung volume is going to increase, that leads to increased total pulmonary vascular resistance. If your lung volumes are very minimal, that is also going to increase your pulmonary vascular resistance. Hence, your pulmonary vascular resistance is minimal or optimal or neither at functional residual capacity. So you have to ventilate any child of ARDS at functional residual capacity. Reason because of your pulmonary vascular resistance as a component. So ultimately, so far, if someone has understood pathophysiology or not, these two slides, even if you don't understand so far, if you can go through these two slides, probably you'll understand the pathophysiology. That is sufficient. So we have shown you what is normal alveolar capillary membrane, and this is a disrupted alveolar capillary membrane due to ARDS. You have alveolar capillary membrane dysfunction, you have edema formation, you have surfactant dysfunction. Because of this, you have decreased compliance and increased resistance. Because of this, you will have alteration in your gas exchange. So if you see that in the X-ray or CT, see if you have a CT picture or X-ray picture, you will have certain aspects of a normal lung. This is a normal lung, and over here you will have a little over the upper part of the lung. You will have a little over distended lung. Over here you will have a normal lung. There will be lung components with edema. There will be lung components with consolidation. There will be lung components with atelectasis also. So that makes us, you will have a 3 different zones of ARDS, which are, one is, we have unstable tissues between this over distended tissues and completely collapsed tissues. That's briefs up the pathophysiology of ARDS. Now let's go into baby lung concept. Before we go into baby lung concept, I'll ask a few people. I think is it mute for everyone still? So what is baby lung in ARDS? What is baby lung in ARDS? Is the lung in ARDS is heterogeneous or homogeneous? Second, what is compliance that we have already discussed? Change in volume to the change in pressure is your compliance. And fourth important concept, what is driving pressure? That is what we are going to discuss. What is baby lung, by the way? See, this baby lung first was coined in 2005 by Gattinoni. So you see, this is an adult X-ray and adult CT chest. You see certain part of the area is atelectatic or is having consolidation, and some portion of the lung is normal. The rest of the portion of the lung is not involved in gas exchange. So thereby, a big adult having only very small tissue of lung which is normal, rest of the lung being completely not involved in the gas exchange. Hence the word that has come up over there, that is a baby lung concept. So this, a big adult having a normal small lung that is being involved in gas exchange, rest not being involved. There is, this lung is a small lung is of a small baby, hence the baby lung concept has come. This is coined by Gattinoni in 2005. So your oxygenation and shunt were related to your non-aerated tissues. Static lung compliance or residual that belongs to your baby lung. That will go into little details. So if you see this, this is completely, we have got this lung is a heterogeneous part. This B part is, a little hyperinflated or normal lung part, I will say. This is the transition zone. This is completely atelectatic lung, which is not involved in the gas exchange. So if you see it as a cross section, if you see this is completely zone of atelectasis, this is zone of over distension, this becomes a transition zone, and this is the normal lung part. So that is why in ARDS of adults, you have a lung part which is equal to 5-6 years age group of lung. That's why it is called baby lung. Your compliance of the lung tissue is related to your baby lung, not with the non-aerated part. So this is your non-aerated part. Your compliance of the lung is belonging to this part of where it is aerated. So why it is important? Why we need to understand this? Do we need to go through these details to understand this baby lung or aerated tissue, non-aerated tissue? Why we need to go through all this? What is the point in going through this? The only reason is, if you calculate your tidal volume as per your ideal body weight, not if you are not calculating as per your baby lung or the aerated tissue of the lung, and if the baby lung is very minimal and you are trying to give more volume like a total lung, even if you have 6 ml per kg of tidal volume, even a 6 ml per kg of tidal volume will be more for that baby lung. Your ultimate principle is you have to ventilate or oxygenate only that baby lung only, not the entire lung, because the entire part of the lung is not going to be involved in the gas exchange. You are going to only ventilate or oxygenate from only the baby lung. So the baby lung is a inhomogeneous, which is a gravity dependent. Why it is gravity? Why we need to know gravity dependent? Because of this concept only, you will be able to prone the child. It is a functional concept, not an anatomical concept, because it can change from position to position. It it is not a stiff lung, but it has got normal elastance. It's not, I would not say it is a healthy lung, but it's an aerated lung part in the total ARDS. See, if you have a small baby lung, there is a greater risk for ventilator-induced lung injury. So, baby lungs has to be dealt very carefully, because if you give more pressure or more volume, even the baby lung that is aerated lung will have a more damage. So, then that's about the baby lung concept. And now we will talk about driving pressure. So, a very important concept called driving pressure in ARDS, because many of the studies, the mortality, one single factor that has decided the mortality or morbidity in ARDS is driving pressure. If you have the way you manage your driving pressure has clearly shown, many retrospective studies have showed that if you have good control on driving pressure, if you are able to manage the driving pressure well, your mortality risk will be less. Where multiple amateur studies have clearly showed that. So that is the reason we have to understand your baby lung will decide the amount of driving pressure. And the driving pressure, if you control the driving pressure, then you will have a good outcomes in your ARDS management. As we have discussed previously also, even a 6 ml per kg of tidal volume can produce over-distension or ventilation-induced lung injury if your baby lung volume is less. Now, what is the driving pressure? So if you see normally, what is compliance? Change in volume to the change in pressure. If you see this definition, compliance is change in volume to the change in pressure. So if you see delta P, if you bring this to here, change in volume to the change in compliance, that is your delta P. That is your driving pressure. Available tidal volume to the compliance of the respiratory system is driving pressure. This is actual definition. Driving pressure is the tidal volume available to the compliance that is available in the respiratory system is your driving pressure. If you calculate, if you ask me as a formula, P plateau minus PWP is your driving pressure. So there ends the talk on the baby lung and driving pressure always. So this, I'm just giving a brief idea about the baby lung concept and driving pressure. With this basic understanding, in the next session, we are going to talk about again a little more about driving pressures, P peak, P plateaus, important components to understand, and few statements from PALIC 2 guidelines. Third, we're going to talk about ventilator management in ARDS. Fourth, non-pulmonary ancillary treatment that is available for ARDS. So for today, we have spoken about ARDS definition, pathophysiology, and briefly about baby lung.